Have you ever seen these historic photographs of patients in catatonic posturing? I think it's safe to say these are patients who were frozen like this and had been for some time when the photos were taken. Though there are a few where it may be that the patient was in motion, like this guy, maybe hopping up and down, for example. But certainly there are accounts of, in the days of asylums, before there were any psychotropic medications that could help with severe mental illness, of just entire wings of the asylum that were people frozen like statues, like a great hall of statues. Patients just posturing, standing in these sorts of positions, frozen. So let's talk about what this is and what causes it, because you can still see this. So picture this. You're shadowing a doctor in the hospital, and you follow him into a room where you see a patient lying in a bizarre position on their bed. The doctor asks the patient if they can check their limbs for rigidity, but the patient says nothing. Their eyes are open, but they're staring straight ahead, hardly even blinking. The doctor asks again, and then gently moves the patient's arm to an outstretched position, and the arm just stays there, holding this new position. You have an eerie sensation that this patient resembles a figure in a wax museum. A nurse brings in a medication, lorazepam, generally classified as a sedative, but soon after the patient receives it, they seem to awaken out of this stupor. They can move freely, make eye contact, and converse. Likely they'll have no memory of having been in this frozen state, but sometimes maybe they do recall some sense of impending doom, or perhaps have a dreamlike memory of being in a frantic internal world that they can't quite put into words now. This is catatonia, and it's one of the most striking presentations in psychiatry, and one of the only times that we can see an immediate, almost miraculous appearing recovery with an acute intervention. And yet, it's also a condition that's notoriously mysterious in terms of its pathophysiology. So that example case I started with is probably what most people think of when they think of catatonia. You know, when someone goes catatonic, as you hear, they're going into this silent, staring, frozen state, right? And that is probably the most common type of catatonia, although possibly it's just the most commonly recognized type. Because really, when we talk about catatonia, we're talking about a heterogeneous syndrome of psychomotor behavior. That's the key thing, that there are motor symptoms, but in a patient with the apparent physical capacity to move normally. So it's not due to abnormalities in muscles or peripheral nerves or structural brain lesions, as from seizures or strokes. Rather, its origin seems to be in the higher order cortical or mental processes, hence the psycho part of psychomotor. But crucially, it's also not thought to be volitional, meaning people with catatonia aren't choosing to move abnormally, and really they don't seem to even be aware that they're in this altered state of motor behavior. So in terms of those heterogeneous symptoms, there's a spectrum of catatonia that we can kind of put onto two axes. So one axis goes from hypokinetic or withdrawn to hyperkinetic or excited. Hypokinetic is where movements are slow or even absent. There's often no speech, so mutism, or perhaps very simple but repetitive speech, like repeating the last word of each sentence they hear, which is echolalia. There's less or no food intake. Overall, it's that classic kind of frozen presentation. Hyperkinetic or excited catatonia, on the other hand, is often missed as even being catatonia because it can look so different. In the historical literature, this was sometimes called manic delirium, but it's essentially a state of agitation, but more specifically, hyperactive but purposeless behaviors. So for example, bizarrely exaggerated movements of the limbs, like walking and kicking steps for no apparent reason, jumping up and down on one leg, punching walls. One I remember clearly is a patient that would suddenly just bolt down the hall, sprint to one end of the hall, then sprint back, then back, not looking for an exit or looking for anything. Really, it's that purposelessness that tells you this is probably catatonic behavior and not merely agitation or hyperactivity. There's something about it that just appears unconscious. In hyperkinetic catatonia, speech can again be repetitive and meaningless, but may be faster in this case. It may be obsessively repeating phrases, which is called verbigeration. So most patients are going to present in one or the other of these states: slowed hypokinetic or fast hyperkinetic, abnormal state of movement. But you can see a kind of alternating or mixed catatonia where the behaviors kind of shift between these two states. And then there's the other axis, which we can put up and down, and that's malignant versus non-malignant. So this is determined by the presence or absence of autonomic instability. And you see this with abnormal vital signs, really. So fever, increased heart rate, increased or fluctuating blood pressure, and decreased blood oxygen level. There are also some findings on blood work that can support the diagnosis of malignant catatonia, like increased white blood cell count, increased creatine kinase, but these aren't specific to the syndrome. They're rather correlated with it. So you have to kind of take everything holistically to make the diagnosis. But so either hypokinetic or hyperkinetic catatonia can be malignant, can progress to malignant. So that's why you'd be monitoring vital signs. And at the point where you see malignant catatonia, that is an emergency and the patient needs immediate intervention. But so what a strange syndrome, right? And you would think we know what causes it, but do we? We could say, well, severe mood disorders or psychotic disorders can cause catatonia. But really what we're saying there is just it's seen most commonly in patients who have one of those diagnoses. It emerges in patients with major depression, bipolar, or schizophrenia. But these aren't even the only diagnoses associated with it. You can actually see it in medical or neurologic diseases as well, like autoimmune encephalitis or epilepsy. And to date, when we look at the brains of people with catatonia, there's not a one-to-one correspondence between any particular change in brain activity and this state of catatonia. Now, in fairness, these are small studies, and it is a difficult and fraught process to obtain MRI scans of people while they're in a catatonic state. But there are some correlational findings that kind of make sense, like a tendency towards a decreased functional connectivity between part of the prefrontal cortex, which is responsible for executive control or volition, and the premotor and motor cortexes that coordinate movements. This has at least been found in patients with the hypokinetic catatonia. But again, this is correlational, not necessarily causal. And so I could ask, well, why is there this decreased functional connection between these two regions? Why does the frontal cortex start communicating less with the motor cortex if that is in fact borne out as what's underlying the catatonic state in the brain? So let's think about the first line treatment, which is benzodiazepines, anti-anxiety medications, which act on GABA A receptors, promoting GABA signaling, and thereby promoting a state of relative calm. These are effective in the majority of cases, like the frozen patient that wakes up, comes to when they get a benzodiazepine. So I think the most compelling explanation for this, and the overall most cohesive explanation of an otherwise bizarre and heterogeneous syndrome, comes from evolutionary theory. So Andrew Moskowitz, as far as I know, was the first person to really comprehensively lay out an evolutionary theory of catatonia, which is that it is a reemergent latent instinct, which evolved as a defense against predators. And so the idea is this: predators are scanning their environment primarily for movement, right? They're looking for something moving. So if a prey animal suddenly detects a predator nearby, one adaptive strategy is to freeze. in hopes of avoiding detection. And this is called tonic immobility. It's where all movement ceases. And, I've seen this in a prey animal once when I was walking along the Appalachian Trail at night with a couple of friends. We heard a rustling along the edge of the path. And my friend shined his big flashlight towards the sound. And right at that moment, this little field mouse just froze right there by the path. And it was so strange to see because mice, they're always moving so frenetically when you do see them. They're always scurrying around, right? That's what mice do. But this little guy was not moving at all, other than you could just kind of see his breathing. And so, my friend turned the light away and we all went our separate ways. But yeah, so mice are just one example of an animal that still uses freezing as a strategy to, tonically immobilize itself, such as when they detect a snake. And in light of that, it's also interesting to consider the ancient Greek myth of Medusa. So Medusa was a monstrous human female with venomous snakes instead of hair on her head. But what actually made Medusa deadly? It wasn't that these snakes were ever biting people in the stories about her. It was that merely looking at her directly would turn you into stone. So I think, as often happens with myth, there's some ancient truth being distilled here, in this case about hypokinetic catatonia, as this risky state we can go into in the setting of deep-rooted fear. The fear of the Medusa and those snakes reawakens this ancient instinct to freeze, turn to stone. Now recall that freezing is just one of the instinctual responses of the autonomic nervous system, so the automatic nervous system, when it goes into survival mode. And freezing is carried out by the parasympathetic component of the autonomic nervous system, but you could alternatively have activation of the sympathetic nervous system, which carries out the fight or flight responses. And I would suggest that perhaps it's this system activation, particularly the flight response, that might more so trigger the hyperkinetic or excited form of catatonia. So as in the freeze response triggering the withdrawn hypokinetic state, if there's a particularly automatic and intense activation of the fight or flight response that overrides typical conscious awareness from the frontal cortex and executive control, you would go into this state of excited catatonia, perhaps. Now, why is it that most people go into fight or flight or even mild freeze modes without actually going into a clinical catatonic state of, purposeless motor behavior, freezing, or the like, while others do? So perhaps this is where differences in individual susceptibility may be explained by differences in brain region connectivity or in responsivity to certain neurotransmitters, GABA glutamate balance, these sorts of underlying biological variants, which may also be influenced by prior environmental stressors or metabolic loads of certain diseases, all sorts of factors. But I think the unifying trigger for susceptible individuals is the activation of the autonomic nervous system to a perceived survival threat. Something gets interpreted as a threat to survival, whether it is or not, and that sets off the initial cascade. And moreover, the degree of a progressive autonomic dysregulation from there might seem to determine who goes into a malignant catatonia, the emergent state. So I think this is an interesting theory, not one that's necessarily proven or even provable, but which, again, I think makes the most sense for explaining how this kind of diverse psychomotor state that we call catatonia comes from. Thank you for your attention.